So my name is Samia Hurst-Majno. I teach biomedical ethics at the Medical School of the University of Geneva, and I'm one of the organizers of this Brocher Summer Academy, where we talked a lot about equality and inequality in healthcare and about tiering in healthcare systems. Most healthcare systems have the ambition of having a single tier system where everyone gets the same, hopefully generous package of healthcare access. But increasingly, there is the realization that this doesn't actually happen exactly like that in most countries. There is some multiple tiering going on. And so the question is, when is that unjustified? When might that be justified and why? And we spent a lot of fascinating discussions about that. My own work connects with this on two counts. I've done work in healthcare rationing. When is it okay to not give access to, for example, really expensive interventions that don't do much good, right? Where is the limit here? If they do some good but really little and they cost a lot, could it be okay to not provide access to them? Could it be okay if you only get access if you pay? I remember once telling a journalist that it probably didn't matter all that much if only the rich could buy interventions that didn't work very well. But there are actually other implications, because if some people have access and others do not, what does that say about the equal regard that we owe everyone? And there are problems there. This touches to my other area of research, which is what is vulnerability? What does it mean to be vulnerable? Who is vulnerable and why, to what, and how can we tailor protections to show equal regard for everyone? Because vulnerability, in a way, is the name we give to situations where it's harder to protect everyone's rights the same. I'm working on several projects at the same time, most of us are, but I'm really excited about a project on trust and trustworthiness in the healthcare system, because of course people come to healthcare systems with many different expectations, some of them explicit, very clear, others much more implicit. And in order to be trustworthy, we must be able to, on the one hand, in order to be trustworthy, we must first be able to fulfill the realistic expectations in a manner that is competent, reliable, and honest. And we must also be able to explain why we can't fulfill the unrealistic expectations. Now, one of the expectations against healthcare systems that has been weaving in and out of many of the talks this week is that healthcare systems are a way in which society tells us what we are worth in the eyes of others. There is a question of regard. Am I being taken care of? Is my need being acknowledged? Is my suffering being met with somebody's care? And is that happening sufficiently equally for everyone so that I feel that I am worth the same as others? This is not an explicit expectation, but healthcare systems in some countries are the only place where people get somewhat equal regard. And we know this because sometimes they come to health systems with the expectation of not being treated like others and are surprised when they actually are. Now, this distribution of respect, this is something that plays into trust and trustworthiness, and is certainly going to be one of my take-home messages from this Summer Academy into the work on the clinician-patient relationship. So one of the very obvious challenges to work on equality and inequality in healthcare is the rising level of inequalities in societies generally. Not just how great they have become, but how accepted they seem to be. It's becoming increasingly difficult to maintain this more egalitarian setting in healthcare systems when societies all around the hospital and all around the healthcare system are becoming so unequal. And so this is a part that we need to give more thought to. There is a really interesting book that came out about a year ago by the economist and political philosopher Ingrid Robbins, arguing that in the same way that many countries have a lower limit on how poor you can get and will help you to not go below that limit, there should actually also be a higher limit. There should be a ceiling. This approach is called limitarianism, and thinking about what it means for healthcare is one of the next steps, I think, in thinking about inequality in health. One of the things that gives me hope is to see that although we face these increasing inequalities, we also face increasing awareness, not just that they exist, but that they are problematic. And there is some really interesting curiosity and thinking and intellectual work going on, and there's also an increasing awareness among our students that this is actually not okay, that we need to be thinking about solutions to what is, after all, a very novel situation. In our lifetime, we have not had a situation with such great inequalities, and maybe we lived through periods of time when they were less problematic, and so we did not think of them as problems, but now it's become quite blatant that the problems are there. So the awareness of the problem, in a way, gives me hope, and the awareness of the problem among younger generations also gives me hope. Here at the Brocher Summer Academy, we start every day with an introductory topic for young researchers about population-level bioethics. Actually, some of the older researchers attend these lectures as well, and we've had some really interesting discussions during them. Mine was on vulnerability, the definition of vulnerability, how we should understand who is vulnerable, why, what protections are appropriate, and there's some really interesting thinking that hasn't happened yet about how that should help us to think about multiple tiers in healthcare systems. What are people vulnerable to if healthcare systems are no longer single tier? What are people vulnerable to if healthcare systems are single tier? And what kinds of wrongs should we be most concerned to protect people against?